Thank you for joining us today. We hope to be able to answer your questions about breast reconstruction. I think there were some questions that were submitted previously. We can start with those until people submit questions live. Do you want to start?
Sure. One of the first questions that was submitted before reads like this. Will a latissimus flap make my back look bad? I'm trying to decide between a lat flap and tissue expanders and implants. If I go the lat route, will I still have to have tissue expanders, or would you just do the flap and implants? So this is a very good question. So a latissimus flap is a procedure where part of the muscle of the back is used to do a reconstruction. And a small segment of skin is also included with that muscle to do a reconstruction of the breast on the same side. The majority of the time, a tissue expander or an implant is used during those cases because the muscle doesn't provide a huge amount of volume to the reconstruction. So if a woman undergoing reconstruction has a breast that is large, by I mean that maybe a C cup or a D cup, it probably won't be sufficient to do the reconstruction solely with a latissimus flap, and a tissue expander or implant would be required in those situations. There is an alternative procedure where a slightly larger volume of fatty tissue is used with the latissimus, and that is called an extended latissimus flap. In those situations, we do not need a tissue expander or implant. The only drawback to that procedure is that it is associated with a little bit slightly higher incidence of complications in the site where the latissimus came from. In terms of the aesthetic appearance of the back after one of these procedures, we're usually able to place the scar along where a normal bra would be located. Therefore, if a woman wears a low-cut dress, the scar would be hidden within that dress. So it would not have a significant detrimental negative impact on the aesthetics of the back if a latissimus is required. So I hope that was able to answer that question.
The next question is to please explain the difference between a TRAM flap and a Diep flap or Diep flap. And then the second part of that is, why don't PRMA surgeons perform the TRAM? I guess first off, the names of the flaps. The TRAM flap stands for the transverse rectus abdominis myocutaneous flap, so it's easier calling it the TRAM. The Diep flap is named after the deep inferior epigastric perforator. So the skin and fat that's used to reconstruct the breast is essentially the same from both flaps, but the blood supply and how the tissue is transferred is different. With the Diep flap, we trace blood vessels through the muscle on the abdomen so that we're transferring skin and fat and blood vessels to keep the tissue alive. With the TRAM flap, it's essentially the same skin and fat tissues, but a portion of the muscle is also moved along with the skin and fat. All of us have performed TRAM flaps in the past. We feel that the Diep flap is better in that it preserves the abdominal muscle, which cuts down on risks of complications such as hernias later, and it's not necessary to move the muscle with the skin and fat. So we believe the Diep flap is a better procedure, and that's why we choose to perform it.
Do we have any questions so far from the web? No. Okay, the next question previously submitted reads, Who is a candidate for Alloderm one-step? Why do some patients need expanders and implants while others can just go straight to implants? Also a very good question. Just for clarification, an Alloderm one-step procedure is a procedure where a breast is reconstructed at the same time as the mastectomy, where an implant, a permanent implant, is placed, and part of that implant is covered by a material called Alloderm. Alloderm is cadaveric skin that has been washed of all the cellular material that previously belonged to the donor, and is very safe tissue to use. And the reason why that is important, or the reason why that is used, is because the lower half of the implant is going to be is right next to the skin. Therefore, we need some padding on the lower half of the implant to produce a more natural appearance. The upper half of the implant is usually covered by the muscle in the chest, so the muscle would, half of the implant would be underneath the muscle, half of the implant would be underneath the alloderm. In these situations, the procedure is able to produce the full reconstruction in one procedure, as opposed to a staged procedure or the typical procedure, which involves putting a temporary implant called a tissue expander underneath the muscle, also utilized with Alloderm, and over a period of weeks following surgery, that tissue expander is gradually filled in order to get the amount of volume that the patient desires. The tissue expander would ultimately be removed and exchanged with a permanent implant. So the ultimate result of the reconstruction is the same, which is a permanent implant covered by Alloderm on the lower half, while the upper half is covered by the muscle. Usually in our experience, Alloderm one step is used in a small number of women because of, if there is any risk of the woman requiring any radiation to the chest after the mastectomy, the Alloderm one step would yield a suboptimal result and would require further surgery to address any contour problems that are caused by the radiation to the breast after surgery. The quality of the mastectomy is also an important feature, or an important factor in being able to do Alloderm one step. If the mastectomy is not done very uniformly, some contour problems can arise, which will require a second surgery. So ultimately, the benefit of having Alloderm one step is that only one surgery is required versus two surgeries. However, in our experience, there is still a relatively important thing to consider, is that there is a relatively high incidence of revisionary surgery or second surgery if Alloderm one step is necessary. So the benefit may not be as great as initially thought.
Okay. A follow-up question to that one is regarding the Alloderm. The question asks, I heard Alloderm is made from human skin. What exactly is Alloderm, and do you use the product that is made from pigs as well? Alloderm is a product brand name. What the material is processed cadaver skin. So after somebody dies, they donate their skin to be used for medical purposes. The skin's processed to remove cells and the outer layer of the skin, keeping the dermis, which is the thick portion of the skin, and that acts as a framework for the patient's own tissues to help heal. The skin is tested thoroughly to make sure that a patient isn't going to contract a disease from using the product prior to being processed. The other product, a similar processing method is done for porcine or pig skin as well, and it yields another type of graft material. It can be used in the breast, and there are surgeons that do use it. I prefer to use the allograft, the human processed skin, because it generally feels softer. I use the porcine or pig skin more for abdominal wall reconstruction because it's thicker and more firm, so it's a better product for that.
I have a question coming in here.
Okay.
It's from Facebook. The patient says, I'm part of an international Diep flap support group. Some of the women report that they have had a rib removed during surgery. Why would that be necessary?
I'll go ahead and take this one, Gary. The reason why a rib is removed, or actually not a whole rib, but only a small portion of the rib, maybe about 1 to 2 centimeters of the rib, where it meets the sternum, is removed in order to get access to the blood vessels that will be providing blood flow to the tissue that is moved from the abdomen over to the chest. That allows good exposure of the blood vessels. The blood vessels are very small and very delicate. There are some surgeons that sometimes do these procedures by going between the ribs instead of removing a rib. The problem with that is that it causes, it potentially can injure the blood vessel because of the limited exposure, and it makes the connections of the blood vessels much more difficult, therefore adding a significant amount of time to the surgery. Ultimately, the removal of that rib does not hinder the mechanics of the lungs, so a woman would not experience any problems breathing after surgery. There is sometimes some pain that lingers in that area for a few weeks after surgery. Ultimately, that pain resolves completely, and the woman never really has any long-term consequences from removal of a very, very small portion of rib.
We can continue with the questions that were submitted before. A person asked to explain the Diep flap procedure. The surgery transfers skin and fat from the abdomen, and we use it to replace the breast tissue that's removed during the mastectomy. I first look at the patient's abdomen to look at what amount of tissue is extra or redundant that I can take and use to reconstruct the breast. I usually listen for blood vessels on the abdomen because the surgery is really planned around getting blood flow to the tissue to keep it alive. So once I find the blood vessels, we make an incision on the abdomen around the tissue that I plan to move. And then we lift the tissue from the abdominal muscles, looking for these perforator blood vessels that are going to keep the tissue alive. Once we find those blood vessels, we make an incision in the muscle and trace the blood vessels down through the muscle. Beneath the muscle, smaller blood vessels merge up to form larger ones, and the larger blood vessels are traced down to where it begins, down in the groin area. Once the abdominal tissues are dissected and ready to move, then blood vessels are prepared at the chest, like Dr. Ochoa explained. Then the tissue is disconnected from the abdomen by cutting the blood vessels, and the tissue is moved up to the breast area, and the blood vessels, or an artery and a vein, is reconnected up at the chest, and that keeps the tissue alive. Usually the time where the tissue's disconnected and without blood flow is only about 20 minutes, and that's short enough time that the tissue is still alive. And then I shape a new breast from the skin and fat that we've moved, and the abdominal donor site where we took the tissue from is repaired like a tummy tuck. The other skin and fat on the abdomen is loosened, and the two edges are pulled together. So it creates kind of a tummy tuck effect on the abdomen and provides healthy live tissue to reconstruct the breast.